I'm going to talk now about a controversial topic in small cell lung cancer, and that is the issue of whether we should be doing surgery potentially for the minority of patients with small cell lung cancer that appears to be very early stage. That's not the majority of patients with small cell lung cancer, but the issue comes up from time to time, and we'll talk about why we might consider that. To start with, we'll go over some basic principles about how small cell lung cancer tends to behave and the demographics behind it. What we've actually seen over the last several decades is an ongoing decline in the incidence of small cell lung cancer. When I was in medical school, we were taught that small cell lung cancer accounts for about 25% of lung cancer, and by the time I was in my residency training after medical school, it was about 20%. Then 15%, and pretty much every time we look, those numbers are going down to now 13% or less of the lung cancer in the United States. Why that is somewhat debatable, but what we typically see is a breakdown in the staging that is 1/3 limited disease and 2/3 extensive. And although there is a staging system that goes from stage 1 to stage 4 in small cell lung cancer, like non-small cell lung cancer, most of the studies and our treatment approaches are really based on a breakdown of whether the cancer is limited to the same side of the chest, the main cancer and lymph nodes involved all within what could be treated with one radiation field, radiation port, or whether it is extensive, that is spreading to the other side of the chest, to the liver, to the bones, the brain, adrenal glands, etc. Most of the time, even limited disease involves lymph nodes nearby and often in the middle of the chest. And it's really only about 5%, if that proportion, who have what some have termed very limited small cell lung cancer. That would be stage 1 or stage 2, where there's no nodal involvement in the middle of the chest, the mediastinum. Importantly as well, most patients are not staged with surgical procedures, and the available evidence is that when we have done more detailed staging, such as surgery, even a limited surgery, we find that a lot of the patients who on scans don't appear to have involvement of nodes actually do. So we may be over-interpreting the proportion of patients who have very limited disease because we're only assessing on our CT scans or PET scans, which may underrepresent the extent of spread. Small cell lung cancer tends to spread early on, and because of that, and the fact that it is so sensitive to chemo and radiation, at least initially, the main treatment approach with curative intent for patients with limited stage small cell lung cancer is a combination of chemotherapy and concomitant chest radiation. Now, surgery is certainly something that may be considered, and it has been done before, particularly for patients who seem to have this very limited small cell lung cancer, that is either with no nodes involved or maybe with some N1, that is lymph nodes involved that are within the lung but not in the middle of the chest between the two lungs, disease. So we'll talk more about why we might consider that. Really, the main support has come from a series of retrospective studies looking back at the experience at a single institution, often over a course of several decades. And in the studies that have been published on the results for patients who have undergone surgery for early small cell lung cancer, they have largely been encouraging enough for the authors, who are usually lung surgeons, to advocate that we think about this more significantly than in general we do in the cancer community. You can see from the table in the middle of this slide that these studies, first of all, are still with small numbers of patients, even though they are collecting patients over all of them more than 10 years, and in some cases 30 years. But we're talking about a few dozen patients, and when you really restrict to the patients who appear to have stage 1 small cell lung cancer, you're talking about anywhere from 18 to 48 patients in the largest series, and that is over a course of many, many years. The results do look pretty favorable, with 5-year survival in the range of 27 to even 42%, for the overall resected population, and higher than that in the patients with stage 1 disease, even in some cases beyond 50%. But a key point to make is that we're talking about a very, very limited group of patients over many, many years at centers that have been treating many cancer patients. So this is clearly not for the majority of patients, and a key question is whether there is something different about these patients, and maybe it has more to do with the cancer than with the treatment that these patients have undergone. What we can say is that there really are other settings in lung cancer or other thoracic cancers where these kind of questions have come up, asking whether it has more to do with the unique characteristics of the cancer itself than the treatment that we pursue for it. For instance, indolent, slow-growing bronchioloalveolar carcinoma, or BAC, has been associated with a very prolonged survival, certainly in patients with very small, early-stage lung cancers, and even in patients with more advanced multifocal cancers. And because of that, people have asked whether the treatments that we use that seem to produce better results than we see in other lung cancers is really because of the great effectiveness of our treatments, or just that we're seeing the natural history of a slower process. We've seen in patients who have limited mesothelioma, who may have surgery and do very well, the question of whether they're doing well because they had the surgery or because they were unusually fit and had unusually limited mesothelioma, or a mesothelioma that responded especially well to chemotherapy before surgery, raising the question of whether it really was the behavior of the cancer and not the issue of the surgery conferring the great benefit. We know that patients who have preoperative chemo and radiation for, say, a stage 3A non-small cell lung cancer do better, and often far better, if they had a very good response prior to surgery. And the people who had no evidence of any residual cancer at the time of surgery, or at least clearance and sterilization of areas of nodal involvement, do much better over a long-term period. And we don't know whether it's because the subsequent surgery did a great job, or whether the people who responded the best were going to do very well because they had very responsive cancer. And finally, the issue of patients with a very low tumor burden, people with a so-called precocious metastasis to the brain or the adrenal glands, who sometimes defy all odds of how well a patient can do with so-called metastatic disease. We don't know whether it is because they were treated very aggressively for metastatic disease or because they had the unusual situation of having a very low tumor burden over a long period of time that made them a remarkable case, even regardless of how they were treated. So this issue keeps coming up about whether it's really the treatment or is it the value of patient selection. The new issue that has come up, or I should say, what has really stimulated the further discussion of this question is an analysis of a large database called SEER, just published in the Journal of Thoracic Oncology within the last couple of months, looking at the outcomes for a little over 1,500 patients with stage 1 small cell lung cancer who were treated at a wide range of centers in the United States over a 16-year period. Of those 1,500 or so patients, 205 underwent a lobectomy surgery and didn't receive postoperative radiation, which is a debatable component of small cell lung cancer treatment in patients who have undergone surgery. And so it really isolates the potential value of surgery as the local treatment for the cancer that you can see. And what the study reported was that the 5-year survival for the patients who underwent surgery was about 50%, and that was more than was seen for the 5-year survival for people who did not undergo surgery for stage 1 small cell lung cancer. There are a few important caveats to add. I mentioned earlier that for the patients who haven't undergone surgery, that is really a combination of patients who truly have stage 1 disease and patients who on scans look like they have stage 1 disease, but would have been found, had they gone to surgery, to have more advanced disease. So we almost inevitably see that the surgically staged populations in lung cancer and other settings do better than the people staged without surgery, because it's a higher bar to be stage 1 after surgery than based on scans alone. Another issue is that the patients who underwent surgery may have been the patients who were unusually fit, younger, may have had the smallest tumor burden, smaller nodes, smaller nodules, than the patients who were still stage 1, but for whatever reason were not offered or did not pursue surgery. There are other reasons to be cautious about the role of surgery for even very limited small cell lung cancer. One point is that patients who may be very well suited for surgery are actually very rare, and they can be hard to identify. There just are not that many out there, and at our own center, even though I have several expert thoracic surgeons available who are very eager to do surgery on the appropriate patients, we have only had 2, 3, 4 patients over the last 5, 6 years who have really been candidates for surgery and have undergone surgery for small cell lung cancer. And in fact, most of those who have were actually not known to have small cell lung cancer until after their surgery. They underwent surgery for a nodule in the lung that was presumed to be a lung cancer, but was not known to be a small cell lung cancer beforehand. And that's often the way that we learn about patients having small cell lung cancer that is very limited stage. It's an incidental finding for people who have already had surgery. Another key issue is that many patients who are seen by thoracic surgeons are not getting the kind of very attentive and thorough preoperative workup and staging studies that really would need to be done if we're going to routinely offer an approach like this for appropriate patients. That whole concept is predicated on limiting this to the appropriate patients, who would only be identified if thoracic surgeons are very vigorous in their selection. In fact, as shown in the lower part of this slide, a pivotal study was published a few years ago in the Annals of Thoracic Surgery by Alex Little and colleagues, and they looked at the results for over 11,000 patients who underwent surgery at a wide range of institutions in the United States, and found that of those 11,000 patients who underwent lung surgery, only 27% had a mediastinoscopy before surgery. And even of those who had a mediastinoscopy, less than half the patients had any lymph nodes actually removed. They might have looked there, but they didn't take any nodal tissue out, which is really not an effective way of screening for nodal involvement. Only 42% of the patients had any mediastinal nodes taken out during the course of surgery. This is not ancient history, and this is at a wide range of centers throughout North America, throughout the United States. And it just underscores the sobering conclusion that many patients are not getting the detailed and vigorous selection and proper staging that we would like patients to have when they undergo surgery. And that would make me very cautious about surgery being done on not only the few arguably appropriate patients with small cell lung cancer, but many who would not be well served by this. If patients were to undergo surgery and have residual cancer left behind, that surgery was not a valuable one. We also know that chemotherapy has been the cornerstone of treatment for patients with small cell lung cancer. It's often very responsive. At the same time, we know that undergoing a big lung surgery does not make it easier to deliver that chemotherapy. And this table comes from the postoperative experience in patients with non-small cell lung cancer, which is certainly emerging as an appropriate standard of care and has been for a few years. But the fact remains that it is a challenge to deliver the intended treatment as you would like. And as shown in the column in the middle on completed therapy, only about half to 2/3 of the patients in most of these studies completed 3 to 4 cycles of postoperative chemotherapy. And you can certainly imagine that in addition to the challenge of just giving chemo under any circumstance, the people who are still recovering from a big lung surgery may have particular challenges recovering from the pain, the bowel issues, everything else related to a big surgery, and then moving into chemotherapy after that. And so I would be very cautious about having any less proven treatment like surgery compromise the ability to deliver a better proven treatment like chemotherapy in the setting of small cell lung cancer. Now, there was an accompanying editorial in the Journal of Thoracic Oncology by an excellent and very highly regarded medical oncologist in Toronto, Dr. Frances Shepard, and she raised the challenge of doing a large randomized worldwide study for patients with very limited small cell lung cancer in which patients would be randomized to undergo surgery followed by chemotherapy or non-surgical treatment with a combination of chemo and radiation. And she acknowledged that this would require years of enrolling these rare patients and would require international collaboration. Unfortunately, I really think that this approach is not feasible. These patients are really very unusual, and I think especially if we were to demand rigorous preoperative staging, such as with a mediastinoscopy, we'd find that there just are not enough patients to continue a global trial like this and actually expect to have it completed. At the same time, many physicians and certainly many patients would have their own feelings about whether they want to pursue surgery or not. So the fact is that many people would find it not acceptable to have essentially a computerized coin flip dictate whether they undergo surgery or not. We have found that historically it's hard to do studies that randomize patients to a big issue like surgery or not. And I think that would be a very significant challenge. And given the small numbers of patients who would be eligible for such a trial, I just don't think it is something that we could ever hope to get a large-scale answer to. So in the meantime, I would say that surgery remains an option in the rare and well-selected patients, preferably selected by very attentive surgeons who are skeptical about doing this in patients with mediastinal node involvement. And I think that it's appropriate to say that the benefit from surgery is still unclear, that patients with this stage of cancer may do very well and be cured with chemo and radiation, and may be the very patients who do especially well, even compared with the general statistics for limited stage small cell lung cancer, because they have a different biology that may keep the cancer small and localized rather than spreading over time, which is just not the typical pattern for small cell lung cancer. So I'll close with that and just address a couple of questions that have come in. And one is, if you knew someone had very early stage small cell lung cancer, would you recommend surgery? I've betrayed my bias here. I think I would not be inclined to recommend it. I do think it is worth a discussion and something that I would discuss with the patient and, in fairness, have them see and talk with a thoracic surgeon about the pros and cons of this. I think it is quite reasonable to do surgery if we are confident that someone could get through that and then get the established treatment of chemotherapy. But if there was a patient in front of me who I was not convinced could get through that bimodality approach, I would consider chemotherapy to be the higher priority here. And let me open this up to Dr. Weiss. What is your sense? Have you had any patients prospectively come to you with this, and or have you had patients who, after surgery, have had small cell lung cancer, and how have you approached them?
So I'm not sure I can remember offhand a patient who has prospectively shown up with known very limited stage small cell lung cancer. I think the patients that I've seen, still small in number, are patients who have incidentally been found to have small cell at the time of surgery. Patients who've gone on to get a full appropriate surgery for what was either believed to be a non-small cell lung cancer or for what a mass that was too small to effectively get a biopsy for, in whom the surgery was effectively the biopsy. And then we found out after, and the question was, okay, what do we do now? In the theoretical case of seeing a patient where in advance we know that there's a very limited stage 1 small cell lung cancer, I would not have a problem with surgery as long as there was determination to follow it up with chemotherapy. And I think the most key point here is the one that you've made most strongly and very well through your presentation and answering this question, that we don't know. We don't have large numbers of patients to really address that question with.
What about post-op and managing someone who happens to show up after a surgery for, say, an unsuspected small cell that appears to be a stage 1 small cell? How have you approached those patients if you've had them?
I have had a few of those, and I think it goes back to the old trials in small cell lung cancer, where small cell is a unique example in which in a chemoradiotherapy regimen, it's the chemotherapy that's actually doing the heavy lifting. Small cell is an extraordinarily chemosensitive cancer. And so for my institution, the approach has been to always follow up with adjuvant chemotherapy, regardless of the size of the cancer.
One other question is, someone has said, it's great to know that the incidence of small cell lung cancer is declining, but why are we seeing that? Do you want to field some potential explanations for that?
I have one guess, and I suspect it's in the majority in thinking that it has a lot to do with trends in smoking. I think that the biggest effect may be the effect of filters. Many people, unfortunately, are still smoking, but as the demographics break down, people are smoking with filters more than ever before. The consequence of this is that it's going to be the smaller particles that get through that tend to deposit more distally, far out in the periphery of the lung. And that's going to predispose you more to a non-small cell lung cancer than to the small cell lung cancer that may be dependent on the larger, more centrally deposited particles.
I agree that it's highly likely to be directly related to smoking patterns. We just see far fewer patients who not only are no longer current smokers, but we see less long-time, multiple packs per day smoking, which is not the invariable pattern with small cell, but most commonly in small cell, it's not only in smokers, but in people who have smoked a lot for years. In contrast, what we're seeing more of is never smoker lung cancer and adenocarcinomas versus squamous cell carcinomas in patients with non-small cell lung cancer. And we know that squamous cell carcinoma, like small cell, tends to arise in the middle of the chest, while adenocarcinomas tend to arise in the periphery of the lungs. And that fits in with the concepts that smaller particulates are getting out further in the lungs when you smoke through a filter. And when we were seeing more use of unfiltered cigarettes, it makes more sense you'd have larger particulates causing cancers more centrally in the chest. And in fact, what we see with review of adenocarcinoma versus squamous over time and in different parts of the world, and even in different demographic groups, it really matches with a time lag the transition from unfiltered to filtered cigarettes. So I think that's really the leading expectation, and I think along with that, we're probably going to see a continued decline in small cell lung cancer, which is great, but in the meantime, it makes it quite challenging to do studies that are going to help us with addressing the optimal treatment approaches for patients with small cell lung cancer today. So with that, I'm going to say thank you very much to Dr. Weiss for joining us today.
And thank you. It's been a wonderful opportunity and a privilege to be a part of this community.
Thanks so much for being part of all of it.